Thank you very much. I'm really honored and privileged to join this webinar of the Jaipur Ophthalmological Society and to tell you the truth that I really very fond of your country and the people of India and the culture of India. And I usually feel that it is very close to the Egyptian culture and the people of Egypt. So thank you again. And my presentation is about the myopic. Can you see my screen?
Yes, sir. It is visible.
Okay. Okay. My presentation is about myopic traction maculopathies, but I have changed the title a little bit. So I would like to stress on the vitreoschisis and retinoschisis in pathological myopia, because this is one of the reasons behind this clinical entity. So if we are going to start what is occurring in the posterior pole of the myopic in eyes with pathological myopia. So there is adherent partially detached posterior hyaloid with traction and with or without vitreoschisis or splitting of the posterior cortical layer, what we call the anomalous posterior vitreous detachment. The eye lamp in pathological myopia is altered and is very rigid, and it is believed to be the most rigid structure at the posterior pole of these eyes. What is also rigid is the retinal arterioles, and this has been described in the literature by many authors, and then the progression of the posterior staphylomas. These are the forces acting on the myopic posterior pole. Theoretically, we can come to a mechanism for myopic foveoschisis. It is a battle between rigid and flexible structures at the posterior pole. The rigid structures, as we have said, is the posterior hyaloid, the epiretinal membranes, the eye lamp, and the inner retina with the rigid vessels, and these structures tend to pull the retina toward the center of the eye, and the outer retina, choroid, RPE, and the sclera. These are the flexible structures, and we all know about the progressive elongation of the myopic eyes, whether anteroposterior and sometimes transversely in these eyes, and this act to pull the retina or to pull these structures away from the overlying retina. The spectrum of myopic traction maculopathies include myopic macular hole without retinal detachment, myopic macular retinoschisis, and myopic macular hole with retinal detachment.
Sir, you are not audible.
I'm not audible.
We can hear you.
Actually, I can hear.
Yeah,
we can hear here.
Yeah, we can. I can also hear.
Okay, okay.
Yeah. Should I go on?
Yeah, please.
Okay. These are not separate entities, but they can transfer from one entity to the other. So if we look at this patient, this is the OCT in 2011. The patient had epiretinal membrane and partial PVD. Later on, patient developed this flat macular hole, and then later on, with some traction, increasing traction, the macular hole becomes larger, and then 6 months later, the patient developed myopic macular hole retina detachment. So one type of myopic traction maculopathy can pass into the others. So they are not completely separate entities. I will start by talking about myopic foveal schisis. When we should operate on eyes with myopic foveal schisis, let's have a look on this patient. In November 2014, there was a inner layer retinoschisis, but the macula was attached and the patient was asymptomatic and the patient refused doing any surgery. And later on March 2015, the patient started to develop diminution of vision, distorted vision, and the traction increased and the macula became detached. So the indication for surgery is macular threatening or macular detachment, and this can only be detected by regularly performed OCT. The patient should check his central vision with the Amsler grid and should notice his reading vision. Once there is symptoms, the patient should report, should be examined, OCT should be performed, and the patient should undergo surgery. Let's have a look on this, another patient. In 2017, there was a schisis, but the photoreceptors are still attached. Although the OCT picture is striking, but this patient is still asymptomatic. By the end of 2018, there was detachment of the photoreceptors and the patient started to symptomatize. So the patient presented with macular detachment and the patient underwent vitrectomy, posterior hyaloid peeling, fovea sparing eye lamp peeling over the posterior pole, and this is an air injection, and this is the final result. So this is a patient with myopic foveal schisis, and by the way, the other eye of this patient had a myopic macular hole detachment. So I started by staining with triamcinolone, and it is indispensable to use triamcinolone to have a look on the posterior cortical vitreous, to look for splitting of the retinal, the posterior cortical layers. Here the probe is used to detach the posterior hyaloid, and this should be done gently and cautiously, trying to elevate the posterior hyaloid until it is elevated from the surface of the retina. And then it is peeled to the posterior border of the vitreous base, or as far peripheral as can safely be done. So you have to see the peripheral part of what you are peeling. And then the eye lamp is started to be stained. This is the brilliant blue assisted eye lamp peeling, trying to fashion the flap. This is a multi-layer. I'm trying to fashion a multi-layer flap, or what I call the envelope technique, because you will see we are going to fold the eye lamp flaps like an envelope. So, and this is done from all the sides. This serves to peel the eye lamp from the edge or to the edge of the staphyloma, thus decreasing the effect, the rigid effect of the eye lamp on the underlying retina, and mobilizing the underlying retina. And once the flaps are created, it is brought over the fovea, and sometimes bleeding occurred while peeling the eye lamp. Under PFCL, although there was no hole, but I decided to put the flaps over in order to strengthen the fovea. This is the preoperative with the macula of detachment, and this is 1 month after the fovea-sparing eye lamp peeling, and air was used in this case. This is again a case of myopic foveoschisis. There was a myopic, a lamellar macular hole seen here, and I injected brilliant blue and started to peel the this is a membrane and not the eye lamp, and you can know that from the texture of the eye lamp, of the structure peeled, and the membrane is peeled over the posterior pole and removed. And you have to be also very slow and trying to allow the tissue to relax after exerting the traction. Another injection of brilliant blue revealed the presence of the actual internal limiting membrane, and fovea-sparing eye lamp was performed just as the previous case. My advice is that once you feel that you are not seeing the internal limiting membrane or the stain is faint, you should restain in order to augment the staining of the internal limiting membrane. And you have to be slow, as I said, until the internal limiting membrane is brought over the fovea. And then again, air was used. This is the preoperative. This is the lamellar hole. The retina became attached, and the lamellar hole is closed with improvement in the visual acuity. This is a case of a more simple case of myopic foveoschisis. Again, fovea-sparing eye lamp was performed, starting from the temporal vascular arcades, moving toward the fovea, stopping at least 500 microns from the edge of the fovea, and bringing the eye lamp over the fovea and performing fovea-sparing eye lamp. Well, this is not enough to relax the posterior retina, so we started to peel the internal limiting membrane till the edge of the staphyloma, and then trimming of the eye lamp under PFCL is injected in order to preserve or keep the eye lamp stable, base vitrectomy, and then fluid air exchange. And this is the post-operative. There was restoration of the foveal contour, and the vision improved to 0.4. Progressive retinal reattachment. This is with the case started with this OCT. There was a foveal detachment, so we decided to operate. 3 months later, there was still subretinal fluid, and I was about to put a macular buckle, but I decided to wait for some time, and after 7 months, the macula became reattached and the vision improved, and there was no need to put a macular buckle. So to summarize, the surgical technique in myopic foveoschisis, the rigid eye lamp is peeled across the posterior staphyloma, reaching to the edge of the staphyloma for 360 degrees. It is difficult to peel across the edge of the staphyloma. This increases the flexibility of the retina. The retina can conform to the shape of the staphyloma, and the retina may be able to adapt to further elongation of the sclera. So fovea-sparing eye lamp eliminates the post-operative risk of macular hole formation. What happened if we peeled the eye lamp over the macula? I did this case. This was a severely myopic 41-year-old female. I did an eye lamp peeling and removal, and I was punished by the occurrence of macular hole, and the hole underwent progressive enlargement, and the patient, although at the beginning she had improved in the visual acuity, but the vision started to diminish. So I decided to perform a autologous free neurosensory retinal flap. So diathermy was gently applied, and this under PFCL, the flap is dragged under PFCL slowly along the surface of the retina, never elevates the flap tangential to the surface of the retina, and it is brought to the over the macular hole. And this is the post-operative picture. The vision improved. This is the flap, and you can see that there is a cleavage between the retinal flap and the underlying retina. And according to this OCT, the hole has decreased in size, but it is still open, but the vision improved. So fovea-sparing eye lamp peeling should be the treatment of myopic foveoschisis. We move to the second entity, which is myopic macular hole without retinal detachment, and we have two types: idiopathic macular hole in a myopic eye and macular hole complicating myopic foveoschisis. This is the first type, myopic macular hole complicating foveoschisis. The posterior hyaloid was peeled, triamcinolone assisted, and then the beryllium blue is used to stain the internal limiting membrane. And then again, it is, at that time I was using the tan scraper to create the flap, but I stopped using this technique. And the internal limiting membrane is peeled toward the macular hole, trying to create multiple flaps. This is the flaps stopping at, as I said, 500 micron from the edge of the macular hole, and then the eye lamp is peeled more peripherally in order to mobilize the underlying retina. And then base vitrectomy was performed, and the eye was filled with air, no gas, and no silicone oil. And under air, the flap was brought over the macular hole using the soft tan scraper. This is the post-operative picture. There is flat, the macular hole is flat, closed there are attempts at restoration of the ellipsoid zone, and the vision improved to 0.4. This patient is a highly myopic patient with a myopic macular hole, and the patient also has paravascular two holes, denoting that there is traction along the paravascular area. The posterior hyaloid was peeled, and then the internal limiting membrane was peeled, creating flaps, also starting from the lower temporal arcade, moving toward the macular hole until we created multi-layer flap over the hole, and under PFCL, the eye lamp was brought over the macular hole, and this is the final picture. Again, air was used to tamponade the macular hole, and this is the post-operative picture. The hole is closed with good functional and anatomical results. This is again a case of macular hole complicating myopic fovoschisis, and the technique of multi-layer flap or envelope technique was used. Here is the U-shaped healing of the macular hole. The vision improved to 0.6, and this patient could read. Myopic macular hole retinal detachment, and again we have clinically two types: retinal detachment confined to the posterior staphyloma and retinal detachment extending to the periphery. We start with the first type. This is a patient with a macular hole retinal detachment confined to the posterior staphyloma. The posterior hyaloid was peeled, and the internal limiting membrane was started to peel after creating a flap with the Thanos scraper. And then the flap, the eye lamp, was peeled toward always working toward the macular hole. Until the flap is re-injection of the brilliant blue to augment the stain. And the flaps are brought over the macular hole and then working to peel the internal limiting membrane to the periphery till we reach the edge of the posterior staphyloma in order to mobilize and relax the underlying retina. And then under air, the vision, the macular hole closed, the retina is attached, and vision improved to 0.3. This is maybe an interesting case with a large macular hole developing over an area of Fuchs spot. The posterior hyaloid was strongly attached. I tried to peel it gently, always keeping an eye on the underlying retina. So once there is a spot of bleeding, you should stop peeling the posterior hyaloid, because if you try to peel the posterior hyaloid more, then you will create a retinal break. And then moving to the periphery, the posterior hyaloid was peeled, and then brilliant blue was injected. And in this case, I found it is difficult to peel the internal limiting membrane with the detached retina, so I decided to peel it under PFCL. The macular hole was large, and at one time I thought of creating autologous retinal graft, but I decided to give the internal limiting membrane the first chance. So the internal limiting membrane was brought over the macular hole from different directions. And finally, I could have a good amount of eye lamp over the hole. And in this, because this was one-eye patient, I inject the patient with silicone oil, and this is after silicone oil removal, the vision improved to 0.16. This is a difficult case because of the posterior hyaloid was strongly adherent, and there was multiple paravascular breaks with strong traction along the blood vessels. So I tried to peel the posterior hyaloid or the membrane adherent to the paravascular retina. I could have been to trim it, but finally it came away. And as you see, there are multiple layers of posterior hyaloid or vitreous cases. So you may have to inject triamcinolone several times in order to stain the sciatic posterior cortical vitreous. And you have to remove the posterior hyaloid completely, moving from the center to the periphery until it is removed. So in this way, we remove the first scaffold exerting traction, and then under PFCL, because it was impossible to peel the internal limiting membrane without attaching the retina. So PFCL was injected to reattach the retina, and under PFCL, the eye lamp was peeled and brought over the macular hole, again using a multi-layer technique, and then trying to peel the eye lamp to the periphery. And this eye was filled with silicone oil. Base vitrectomy was performed, and then silicone oil was injected. And this is the picture at the time of silicone oil removal. The retina is attached and stable. This is a recurrent macular hole, myopic macular hole detachment after a previous buckle, and you can see that the buckle was very high buckle. What I am peeling now, this is an epiretinal membrane and not the internal limiting membrane. Re-injecting brilliant blue, and then peeling the internal limiting membrane. Again, always peel from the periphery to the center, stopping 500 microns from the edge of the hole. And peeling till the edge of the staphyloma. Re-augmenting the dye. And then complete the peeling of the now well-stained internal limiting membrane. And then under PFCL, the retina was attached. The eye lamp was brought over the macular hole. And then a small retinotomy was created to drain the subretinal fluid completely. Laser was applied, and finally the eye was filled with silicone oil. This is at the time of silicone oil removal, the retina is attached, and these are different OCT done at different intervals. And this patient was very lucky. This was the one eye, this is the last eye of this patient. The vision improved to 0.6, and the patient could read. So take-home message or stay-home message, because we are at the time of the COVID-19. Anomalous PVD, vitreous schisis, rigid ILM, posterior staphyloma are the main factors contributing to the tractional forces acting on the posterior pole in pathological myopia and resulting in a wide range of clinical entities. The use of triamcinolone to highlight the vitreous gel is indispensable for visualizing the visual layers, cortical, vitreous, adherent to the retinal surface. And ILM is definitely and proved pathologically to be the main scaffold for cellular proliferation. So it is the most rigid structure at the posterior pole. So it is a pathological ILM, stained ILM, and its peeling to the edge of the posterior staphyloma increases the flexibility of the retina and thus can conform to the shape of the staphyloma. Fovea-sparing ILM peeling is the treatment of choice for myopic foveoschisis. Multi-layer ILM flap technique, or what I call the envelope technique, is the, I think, a very good technique for macular hole, myopic macular holes with and without retinal detachment. I think that macular buckling is rarely needed nowadays, and free autologous neurosensor retinal flap or amniotic membrane grafts are better preserved for cases with already peeled ILM. And this is all what I can say about myopic foveoschisis. I hope it is it answers many of the questions about this important clinical entity. Thank you.
Thank you, Dr. Mortada, for showing wonderful videos as usual. And there has been a lot of learning from your videos.
Stunning videos.
And yeah, and all of us feel more confident, after seeing your videos. You see, one question was that you have shown three kind of entities, and you very nicely explained the rigid retina and the flexible retina. That concept actually got ingrained in my mind. And all the three scenarios, whether it is schisis, hole without RD, or with RD, steps of surgery are by and large similar. That is careful PVD, re-injecting triamcinolone, and to stain posterior cortical vitreous, multi-layered flap, and air. And you emphasized air and no gas to be used in surgery. So is this surgery different in three kind of scenarios, or is by and large similar?
No, I think the surgery in the three clinical entities is the same, because we are dealing with a major or a main causative factor, that is the rigid ILM. This is, so when you peel the ILM and when you use the ILM to provide a scaffold for the proliferation of Muller cells that will help closure of the hole, then you will solve the problem. If you have failure after doing this, then you have to perform a macular buckle. But believe me, in doing many cases, I did not find a case that need a macular buckle after several years of follow-up. So the need for the macular buckle may be before the era of ILM peeling and ILM flap technique. But with the technique of peeling to the edge of the staphyloma to relax the underlying retina, creating a flap to cover the macular hole and assist in its healing, as mentioned and described by our dear friend from Poland. So I think this can solve many of the problems in these eyes.
Why did you emphasize that ILM multi-layered flap has to be left short of 500 microns? What is the rationale of stopping at below 500?
Yes, because if you peel it to the very edge of the hole, you may the flap
Lose the flap.
may be lost, may be cut, it may be lost. So you have to preserve the flap. Also, I inject PFCL while doing base vitrectomy, because if you are doing base vitrectomy, there is current inside the eye, fluid current, and this fluid current may detach the flap from the hole.
Yeah.
So you have to inject PFCL to keep the eye lamp flap over the macular hole, then do your base vitrectomy. And then after finishing the whole surgery, you fashion the flap, you place the flap over the hole, and you perform either PFCL air or PFCL silicone exchange, depending on the severity and the complexity of the case.
Professor Mortada,
Sure, sir.
I want to ask you, in a myopic macular hole eye or a myopic schisis eye, no presence of retinal detachment, is it necessary to always do base vitrectomy?
Yes, I'm an old vitreoretinal surgeon, so I learned a lot from Payman, I learned a lot from Zivanovic and from Macular. And at that time, vitrectomy means complete vitrectomy. So I always insist on removing the vitreous base, even in simple idiopathic macular hole cases. But in myopic macular hole, myopic traction maculopathy, removing the vitreous gel from the periphery provide more volume, so you can inject more air inside the eye without the need for injecting gas. And as you all know, the size of the myopic eye is huge. And when you inject air, there will be a large volume of air. And air stays in these eyes at least for 10 and sometimes for 15 days. So in these eyes, there is no need to use SF6 or gas or C3F8. And I think C3F8 has no role in these cases. If you are
not at all.
hindering and the vision of the patient and increasing the duration in which the patient cannot see. So I think air is sufficient, provided you injected you remove the vitreous gel, the peripheral vitreous gel, and you inject a large amount of air.
Thank you very much.
My question was what was the need for injecting PFCL in a case of myopic phobioschisis, and when you already did the phobia spreading ILM peeling? Is it just to keep the ILM in a proper place so that the turbulence while doing the vitreous base excision is happening? Is it only for that purpose you are injecting PFCL? Okay.
Yes, exactly. For this purpose, in order to avoid detaching the eye lens flaps while manipulating the vitreous base, depressing and releasing the depression, and so on. So I think injecting few cc of PFCL over the macular area will protect the flap and keep it in place.
Sir, in such high myopic eyes, while peeling at the posterior pole, you use a contact system or the wide angle system?
No, I'm using a non-contact system. And
so, sir, if you are using a non-contact system, does it happen to you that while peeling the rim of the wide angle system, touches with your forceps, the handle of the forceps?
Yes, very good question. There are certain precautions that you have to take while peeling the eye lamp, because you are dealing with an eye with a long axial length and in a posterior staphyloma. So first of all, you have to adapt the position of the patient head so as to bring the field you are working at nearest to the forceps. Second, you have to use forceps with small hands with small handles. So don't use forceps with bulky handles, because with the small handles, especially the cross-action forceps, they are not going to hit the edge of the non-contact lens. But if the handle is bulky, then you are going to hit the edge of the lens.
Right.
Third, you may remove the trocar, the cannula, the cannula. So this may add few cc or few millimeters, I mean, to your forceps. I don't like to use the long forceps, because the longer the forceps, the less you have control over the tip of the forceps. I think in this way you can use. I'm using what is produced by Oculus. It's called the high definition non-contact lens. It is used for both the macular work and the peripheral work.
Okay, sir.
I'm also exactly using the same one, and that really helps. That
Yes.
if you focus it well in the beginning
Yes.
of the surgery, it stays in focus all through.
Yes, and even now I'm using the Ingenuity system, and I'm doing the same technique. It needs some training, but finally you will find yourself capable of peeling the internal limiting membrane in these eyes. But this doesn't mean that the contact lens is a bad technique. It may, in some hands, it may be the best technique. So you can use the non-contact or the contact lenses.
Okay, sir. Thank you so much. So can I now start my presentation?
Okay, I'll stop sharing.